Well, thank you very much for the invitation to speak at your meeting. My name is Professor Nicholas Embleton, and I am a consultant neonatal paediatrician based in Newcastle upon Tyne in the United Kingdom. And in this lecture, I will be talking about necrotizing enterocolitis and the long-term outcomes and correlations with cognitive, quality of life, and family-related issues. So, as all of you in this conference today will appreciate, there are many aspects to feeding preterm infants which are complicated. But the major issues, I think, involve the risk of survival and also the risk of problems created by conditions such as necrotizing enterocolitis. And so our aims as neonatologists are obviously to maximize survival and optimize the outcome by reducing diseases such as NEC, but also ensuring that we provide adequate growth and particularly adequate nutrients for long-term brain development. And we do all of this in the context of family integrated care. And throughout this lecture, I will be sharing some photos, and I have tried to anonymize these where possible and acknowledge that some of the photos I obtained from the internet or other websites. And many have talked about the tightrope that we face as neonatologists. How do we, on the one hand, ensure that we feed these babies adequately for growth, ensuring we provide all of the macronutrients and micronutrients necessary, but at the same time avoid NEC, necrotizing enterocolitis. And it might be possible to do both of these things at the same time. And in my 30-year career, I have become convinced that better nutrition is key to improved survival, but that as we look after babies who are surviving at increasingly premature gestations, we're recognizing that their nutritional needs are becoming more important and more complex. And as I say, the challenge is how we optimize survival and long-term outcome. And we think not just about what happens on the neonatal unit, but we're thinking very much here about long-term. And in the context of nutrition and growth, we're very interested in how early life growth may impact on later cardiovascular health, later cognition, and later bone health. So how you are fed as a fetus and a baby impacts on your risk of osteoporosis. So we want to optimize growth, but at the same time, we want to avoid NEC. Now, all of you will know that necrotizing enterocolitis is an acute, life-threatening, multi-system inflammatory syndrome. It's not a single disease, it's a syndrome. And it involves inflammation and intestinal necrosis. And it is the end result of multiple different disease processes. All of you will be aware of multiple risk factors and aware of the importance of immune regulation in many of these mechanisms. And the initiating event in most individual cases is never known. And so many infants with risk factors, for example, being an extremely low birth weight infant and not receiving mother's own milk, we recognize many of these babies born with risk factors, but they never develop NEC. And we should ask ourselves the question, why is it that some babies with multiple risk factors never become unwell? Now, trying to find out what NEC means in the longer term is quite different, and it depends on the setting in which you are working and the definitions of NEC. We know very roughly that about 50% of the babies with serious NEC will require surgery, and of these, up to 50% may die. And in the survivors, they experience multiple insults that may harm the developing brain. And the aim of the lecture today is to discuss the mechanisms of brain injury, the longer-term uncertainties, some of the parent perspectives, and then to think about how nutrition and other interventions may improve outcomes. NEC is a very cruel disease. We know that the majority of infants born at 24 weeks gestation will develop bronchopulmonary dysplasia, and all of them will develop some retinopathy of prematurity. But NEC is different, and when it occurs, we often ask ourselves, why did this baby get NEC? Did I start the feeds too soon? Should I have treated the patent duct differently? Did I increase the feeds too quickly? Should I have been using probiotics? Was it the breast milk fortifier that caused it? And this lack of predictability and understanding is heartbreaking for parents. Now, there have been several studies of the longer-term outcomes following NEC. And we know overall that there is a significant higher chance of what we might call worse brain outcomes. But what do we mean by worse or bad or not normal? And we need data. We need data to help us make better clinical decisions. We need data to guide research of new interventions. We need observational studies. We need audit and quality improvement. And most importantly, we need to find better ways of informing parents, because their uncertainty is never ending and they experience very long neonatal journeys. And here are some of the questions that parents might think about on the neonatal unit when they realize that their baby has this very serious disease. They may be worried about what his quality of life will be. They might worry whether the child will grow up and have friends at school. Will they get a job? Will they be able to earn enough money to look after themselves? Or will they need lifelong care and support? What about you as the mother? Will you be able to return to work? Will you be able to resume your career? Are you going to be able to afford the care of your baby longer term? Will you have enough time to look after the other children in the family or to have a normal family life? And most profoundly, is your baby going to survive and go home alive? These are just some of the questions that parents will be asking themselves as soon as they know that their baby has a serious disease that may result in their death and certainly will result in longer-term consequences. Now, extrapolating outcome from all the populations that form the data sets to an individual baby is incredibly difficult. And we have a lack of robust definitions. Many of us are not really sure what we mean by NEC. All of us would agree that where you see necrotic bowel confirmed histologically in a premature baby with classical risk factors, yes, that's NEC. But perhaps we have less agreement in other cases. What about a 10-day-old, 25-week baby with patchy inflammation and an ileal perforation? Was that NEC? Or might that have been some form of spontaneous intestinal perforation? What about a 27-week baby at 20 days of age with possible pneumatosis on the X-ray in association with some feed intolerance and a slightly raised CRP, but who is otherwise systemically well and does not have an operation? Did that baby have NEC? So the diagnosis of NEC is subjective and the outcomes vary. There is a lack of specific and sensitive tests for NEC and a lack of internationally agreed criteria. And so the true outcome for NEC may be better or worse than that is published. So how do we extrapolate the information from all of these population studies to that individual baby in front of us? Now, we can know that if there are extensive findings at laparotomy in the sickest babies, it's not surprising that those babies might have the worst outcomes. Everybody will use some version or adaptation of the Bell staging criteria, but Bell's staging criteria was never developed for diagnosis or grading of severity. The Bell staging criteria was developed to think about the risks of surgery. And most of our follow-up studies are said to include babies with stage 2 NEC or greater, but this might mean different things in different settings. And importantly, the publications do not include the granularity of the illness. We do not know about the specific features of the babies included, how sick they were, how many inotropes they needed, how low their platelets were. So we cannot extrapolate these outcomes to an individual baby. Parents probably are not helped by knowing what the average outcome is for babies with NEC. They want to know what the outcome is for their baby. NEC is an ever-changing disease. The outcome of a 28-week baby diagnosed with NEC 30 years ago, when I started work, might be very different to a 23-week baby who develops NEC now. And if we want to consider the adult outcomes of a baby with NEC, we can only know that really for adults who were born in the 1990s. So everything is changing. So how do we present this information to parents? Well, we need to be compassionate and honest. We need to provide the information bit by bit in stages, not all at once. And parents, when they have been asked in research studies, have recommended that we, clinicians, make improvements. We need to make our information more accessible, more personalized, and more practical. Parents want us to be more positive. They want us to be truthful, but they want us to give messages of hope. They don't want us just to focus on the disease and the disabilities the baby might have. They want us to try and provide them with some hope, with some positive messages about the future. Now, for clinicians, we may want to know the difference in the outcome for a 25-week baby with NEC compared to a baby without NEC. But that's not of interest to parents. Parents want to know the outcome for their baby rather than the independent extra contribution of NEC. What are the important long-term outcomes following NEC? Well, there has been a move in medicine over the last 20 years to develop and utilize core outcome sets. And these are developed through a process of consensus with multiple stakeholders. Ultimately, they are endorsed by an informed panel, and that will include healthcare professionals, as well as parents and adults or teenagers with their own lived experience following NEC. And when we develop these core outcome sets, it can be challenging to include populations from what we call hard to hear groups. How do we learn from families who have socioeconomic deprivation? They are not likely to take part in these core outcome set development. They may lack abilities to use mobile phones or computers, and they may have limited health literacy. So developing core outcome sets is challenging and very time consuming. And even when you develop the final shortlist of outcomes, many parents say this doesn't really reflect what's relevant to them and their family. Clinicians, parents, children, and adults, we all have different perspectives on what this matters. As academics, we may rate cognitive outcomes being more important than motor outcome, but parents might rate things differently. And often for parents, they're interested in the developmental trajectory, see that as more important than peer-matched normals. They don't really get interested in the specifics of the Bailey score, whether it's 90 or 95 or 88. What they want to know is their child's development progressing in a positive direction? And if you ask parents, and all of you who are parents, you would say the same. What's really important to you and your child in the future? Are you really bothered if they get A stars academically at school? Or really, is what you want for your children, for them to have a fulfilling childhood. That's what all of us want. All of us would like our children to make friends and join in school activities. But we recognize that children with NEC, because of the impairments, may be excluded from friendship groups. If they have a disability, other children may see them as different. Having a disability may make taking part in children games difficult. And as adolescents, they may be bothered about the scars they have. They may be bothered about gastrointestinal issues like diarrhea, or the impact of NEC and surgery on their reproductive health. So what matters most changes over time. Now, there has been a lot of very important work, and it's published here a couple of years ago, trying to develop core outcome sets for NEC. And the outcomes they come up with are really not very surprising. These are all the outcomes that you would predict. What's the mortality outcome? What's the physiological clinical outcome? For example, do they have short bowel syndrome? What's the neurodevelopmental impairment impact? And what's the life impact, the quality of life as adults into later life? So let's just think now about what might damage the brain after NEC. Now, there are multiple mechanisms. And there are several factors associated with NEC that also have an independent impact. So, for example, breast milk improves your brain regardless of whether you get NEC or not. But breast milk also reduces your risk of NEC. Now, the primary initiating pathology in NEC involves oxidative stress, neuronal excitotoxicity, and apoptosis. And then with the next few hours, you get a cytokine storm. And these cytokines damage neurons, damage cells, and damage white matter. And this also disrupts the programmed development of brain structures. And it also disrupts connections, what we call the connectome. The cytokines released will cross the blood-brain barrier. There, they will damage various cells, including microglia, and they will interfere with neuronal migration. And furthermore, of course, NEC impacts on cardiorespiratory function and may result in impaired cerebral autoregulation. So there are lots of different processes going on here. And I've tried to simplify these in this diagram. And here I've laid out the different changes that might happen over minutes, hours, days, and weeks. As I say, in the first few minutes and hours, you have neuronal excitotoxicity, apoptosis, damage to brain structures. We have metabolic disruption, electrolyte and oxygen disruption. Babies become intensely catabolic and they have impaired autophagy. And all of this is happening over the first few minutes, hours, and days, and gradually over time settles down. But over the days and weeks following NEC, babies may suffer malnutrition, disturbances to the gut-brain axis, disturbances to neurotransmitters, and all of these impact on brain function and repair. Now, the gut-brain axis is very important. We know that NEC may be due to disturbances to both the microbiome and the metabolome. And then NEC itself will result in dysbiosis because there is a lack of milk matrix in the gut because the babies are put milk by mouth, and then the microbiome is disturbed by antibiotics and other drugs. So this gut-brain axis describes the enteric nervous system comprising trillions of nerves. And all of these nerves interact with brain function through the gut-brain axis. And we know this is modulated by neurotransmitters and hormones, particularly hormones acting via the vagal nerve, differences in peptides and hormones. And in adults, we know the gut-brain axis impacts on motility and bowel habit and weight gain. And all of these impact on CNS activities such as mood and behavior and anxiety. And we know this is a very complex system, and really the work in premature babies is very early stage. We don't understand it, but what we do know is that this is very complex. So this very important relationship between the brain and the gut, particularly in terms of the microbiome, may be hugely important for some of the features of the brain damage we see in babies following NEC. We know that the gut microbiome is very important for brain activity and development. And this data from this study, I like to quote, what we know is that adults with Parkinson's disease often report a history of constipation 10 years earlier. And I think that just gives you a sense of how profound the gut-brain axis might be throughout life. So we know that necrotizing enterocolitis is caused by and causes disturbances to the gut-brain axis. There are multiple pathways, most of which we don't understand. They involve inflammatory and other small molecules such as short-chain fatty acids like butyrate. They involve hormones and microbial products and neurotransmitters like serotonin and GABA and tryptophan. And these all likely have a significant impact on brain metabolism and may indeed reprogram longer-term brain function. So a quick recap. Necrotizing enterocolitis is a complex multi-system disease. There are many causes, including the gut-brain axis. The immune and inflammatory pathways impact on brain development. We get damaged brain cells and connections and disordered development. There is parent and clinician uncertainty on multiple levels. And the outcomes of NEC are complex, significant, and very individual. The diagnosis of NEC is not robust. The development of core outcome sets is very important for research studies, but may not help individual parents. So let's try and understand better what might happen to the brain when a baby gets NEC. Well, as I have mentioned earlier, the period following NEC can be divided into different stages. As I say, in the early acute phase, we have the release of cytokines, but the damage caused by the cytokines may be exacerbated by hypoxia, ischemia, septicemia, and coagulopathy. We know that cytokines are important, and for example, the levels of specific cytokines like IL-6 appear to be correlated with later cognitive and psychomotor outcome, suggesting that the duration and intensity of the inflammatory response may also impact long-term outcomes. There is some evidence that general anesthesia may be a risk to the developing brain. We know that when a baby gets NEC, we need to use antibiotics, inotropes, and lots of other medications, and it's possible that there are toxic or excipient-related side effects. For example, from substances such as benzyl alcohols, ethanol, and propylene glycol. NEC is a very high energy state. We have endogenous release of catecholamines, we have peripheral insulin resistance, and many of these babies will develop hyperglycemia, hyperlipidemia, and electrolyte disturbances, and all of those may adversely affect the brain. And we also know that in the acute inflammatory phase, excess nutrients may overload the cell's ability to break down proteins, what we call autophagy. And this impairment of autophagy may disrupt cellular metabolism, and that in turn may worsen cardiorespiratory and brain function. All of you will be aware of the biochemical response to stress, that following stress, for example, sepsis, we have a rise in catecholamines, cortisol, and glucagon. And in the presence of increased endogenous glucose production and peripheral insulin resistance, a rise in serum glucose is very common. This rise in catecholamines and cortisol also results in protein breakdown and lipolysis, catabolism. This releases free amino acids and free fatty acids. And so if you look at the lipid profile of babies with stress or sepsis, we see a rise in triglycerides and low density lipoproteins. In the late phase following NEC, babies fail to tolerate or receive or assimilate nutrients. And if babies are not receiving milk, then they are also not receiving beneficial breast milk components. They are not getting any milk fat globule membranes or phospholipids or human milk oligosaccharides or brain growth factors such as IGF-1. So that's another risk to the brain. We give all the babies parenteral nutrition. Parenteral nutrition is life-saving, but it also increases the risk of sepsis, which may damage the brain. We know that if you receive parenteral nutrition, you also receive aluminium, which is toxic, and you may receive excess manganese, which also deposits in the brain and may damage the brain. Intravenous lipid is life-saving and essential, but also results in abnormal fatty acid profiles. And when we give amino acids, it's possible that we either give it excess amino acids or inadequate amino acids, and all of this may be harmful to the brain. NEC is a painful condition, and this nociceptive, i.e. pain damage, is very important to the developing brain, particularly certain structures such as the amygdala, cingulate gyrus, and thalamus. Let's think about the recovery phase of NEC. We know how beneficial kangaroo mother care is, but this is challenging if the babies are sick. So the baby's brain does not benefit from KMC. All of us realize how difficult it is to reestablish motility, to get feed tolerance, to allow the baby's time to upregulate digestive and absorptive capacities. So malnutrition is common. It takes days to transition from the catabolic to the anabolic hormonal environment. Babies who have a stoma will absorb less nutrients and lose more nutrients. That's true for macronutrients, electrolytes, and various trace elements and vitamins. The NICU environment is abnormal. Babies are exposed to high levels of sound and light, abnormal touch, and if they are sick, they are deprived of the benefits of comfort holding. Parenteral nutrition is associated with liver disease, which may also harm the brain. And we also know that many of these babies struggle to achieve oral or nipple feeding, and for some, breastfeeding may never be achieved. And all of these are potential risks to the brain. In the post-discharge period, what else might be damaging the brain? Well, we need to avoid or minimize the risk of poor brain development by minimizing and avoiding growth failure. Babies potentially are at risk of micronutrient deficiencies such as iron. Babies may not be receiving breast milk, and therefore they do not get the beneficial components for the brain, such as stem cells, milk fat globule membrane, and human milk oligosaccharides. Early infancy is critical for the development of social networks, and how the caregiver may have been affected by NEC may impact on childhood feeding behaviors. Abnormal feeding exposures in early life may impact on speech and social communication development. And this is particularly complicated and complex if the babies have short bowel syndrome. And we know that babies with short bowel syndrome have lower cognitive, language, and motor scores and worse growth. Why does growth matter? Well, growth is much more than simply weight gain. Growth also includes an increase in length and head in a baby with appropriate body composition. Weight gain itself is not the most important outcome, but weight gain is a reliable marker of nutrient intakes. It's nutrient intakes that matter rather than growth. And if the weight gain is slow, it's possible that there are insufficient nutrients for optimal brain growth. So we need to watch growth very carefully. And when we make the decision about how to feed a baby and we want to emphasize the importance of breast milk, I would always emphasize that breast milk bionutrients may be more important than pure weight gain. We can think about all of the factors I've discussed in terms of impaired brain development by looking at what I've called here the exposome. And the exposome is the totality of all of the exposures. So here you can see I've broken it down into the different phases: the early acute phase, late acute, the recovery phase on the NICU, and the post-discharge recovery phase. And throughout all of these 4 phases, babies may be in an abnormal sensory environment, not receiving enough kangaroo mother care, not getting mother-infant closeness, not being in the right home and family environment. And then we think about all of the other exposures that I've been through: hypoxia, ischemia, sepsis, hypoglycemia in the early phases, impaired nutrient intakes and assimilation, suboptimal fatty acid, and amino acid parenteral nutrition, all of the toxic exposures from drugs and PN, all of the risks of PN associated with dysfunction, then even as the baby starts to recover and receive enteral milk, they may not be getting lots of breast milk, and there may be an impairment of bionutrient intakes, and then the risk of poor nutritional status continues in the post-discharge period. When we talk about what this means for the individual child, we know that NEC impacts on multiple domains: cognitive, socio-behavioral, language, sensory, and motor domains. Now let's just think about the terminology here, and I'm aware that the terminology may differ between countries because of different languages. But I take impairment to mean the loss or abnormality of physiological, psychological, or anatomical structure or function. That's the WHO definition of impairment. Disability is the impact of that impairment. So how that impairment restricts or results in a lack of ability to do your expected things. So how your impairment, for example, your motor impairment, may adversely affect your ability to play games. So if we extend that analogy, we will see that many ex-premature babies have a hearing impairment, but that may not result in a disability if that hearing impairment can be corrected with hearing aids. And then handicap, which may be used synonymously with disability. Handicap to me is a bit different. Handicap is the disadvantage that limits or prevents fulfillment of a role that is normal. So, for example, a child in a wheelchair has a motor impairment, has a disability, but with modifications and support that enable that child to fully participate in school, that child might consider they have a disability, but not necessarily a handicap. And when I was researching for this talk, I came up with these F words. So measuring impairment in infancy is difficult. We know that it's very impacted in neurodevelopment, and that neurodevelopment itself is multidimensional and non-linear. Many units use the Bailey scale of infant development, but this only measures the stage of development, and this is not an accurate predictor of cognitive function in later life. Studies of NEC into childhood are complicated. Brain outcomes can be more robustly assessed in childhood than in very early infancy, but these studies take time, they're very expensive, and they suffer from attritional losses. And this may limit their validity and generalizability. Socio-behavioral and communication impairment has a huge impact on your quality of life, but quality of life is very difficult to assess in an individual before they reach school age or are older. And I quite like these F words developed by Rosenbaum. And so these F words are function. What is the child's activity? Fitness. This applies to the body, the family, i.e. the environment, friends, your ability to participate in society, fun, your personal drivers and enjoyment, and the future, the life that you see going forward. So I've already talked about the importance of the severity and duration of the inflammatory cytokine response in NEC. And we've alluded to some of the complexities of using parenteral nutrition, the lack of breast milk, the adverse impact of antibiotics or sepsis. All of these things combine to result in worse outcomes. And there have been attempts to meta-analyze, systematically review this data. And large studies conducted in higher resource settings show that following NEC, intestinal failure rates may be between 15 and 35%. Mortality rates typically are at least a third of those requiring surgery, but increasing to 50% if the baby was less than 1,000 grams. And that significant neurodevelopmental impairment may occur in between 25 and 60% of survivors. But all of these studies are confounded by inconsistent definitions of NEC, inconsistent definitions of intestinal failure and neurodevelopmental impairment, which makes meta-analysis difficult. Now, there is some data from long-term studies. This was a study in the UK randomizing pregnant women with premature rupture of the membranes to different antibiotic regimes. And I include this here because they saw a higher rate of NEC in the group receiving coamoxiclav. And in this study, 25% of the infants who developed NEC died. It feels fairly relevant to today. And at 7 years of age, they had much greater impairment if they had NEC compared to if they didn't. But actually, there was not very much difference in severe impairment between those with and without NEC. But there were worse behavioural scores measured by the Strength and Difficulties Questionnaire. ADHD appeared to be more common, and there was a higher rate of bowel problems at 7 years of age. So this study gives some quite good detail on what NEC might mean in childhood. And there have been lots of other network studies, German neonatal network studies showing poor head growth and height at 5 or 6 years of age, Danish registry studies showing higher rates of an abnormal stages and development questionnaire, US studies showing higher risks of neurodevelopmental impairment. And I'm not going to go through those in detail, but there is quite a lot of data out there applicable to different settings. And I'm not talking about spontaneous intestinal perforation or focal intestinal perforation today. It's different from NEC. However, interestingly, a Dutch study of infants with focal intestinal perforation showed quite high mortality rates and high rates of hydrocephalus. And they followed up their infants until early adolescence, 13 years of age, and showed that 60% of these very premature infants with intestinal perforation, 60% had disability compared to 40% who didn't. So again, just really emphasizing that these long-term uncertainties exist for infants with spontaneous intestinal perforation as well. What do families say? Well, this is a very large study from Ravi Patel and the NEC Society with over 200 families. About 3/4 of the parents report ongoing challenges in childhood following NEC. And 90% of young adults with NEC report adverse impacts on health-related quality of life and their career. And almost all of them say they were not informed, or that the people looking after them just simply don't understand what NEC is. And when young adults are asked what it's like to live following NEC, they talk about their relationships with food and eating, changes in body image, a whole set of problems not apparent in early childhood, changes in bowel habit, fear of intestinal adhesions, and adverse impacts on fertility. And when they did a content analysis of the parent responses, they could group these into 5 areas. So long-term childhood impacts of short bowel or gastrointestinal function, scars and self-image, social concerns, anxiety or depression, and ongoing access into care. So those 5 areas are the key areas that parents focus on. So what can we do to make things better? Well, first of all, we can do interventions that improve long-term brain outcome, particularly, as I say, focusing here on mother's own milk. Now, this is associated, as you know, with numerous advantages. But importantly, when we think about donor human milk, there is no evidence that donor human milk improves neurodevelopmental outcomes. So we have to give mother's own. So anything we can do to encourage and support mothers to continue expressing milk during the acute phase of necrotizing enterocolitis, acknowledging that they may find this very challenging or even distressing to keep on expressing when their baby is sick. And many of them may be fearful that their baby may not survive to ever receive their milk. And the benefits of mother's own milk are multiple, but again, here I just really want to highlight the importance of exosomes and cells. So exosomes are these tiny vesicles packed with protein, lipids, and nucleic acids. But also the stem cells. Fresh breast milk has millions of stem cells for every ml. And all of these stem cells can enter the gut and may be very important in gastrointestinal repair. So my recommendation is that you should aim to give fresh mother's own milk at least once or twice a day. And by fresh, I mean less than 4 hours, i.e. whilst it's still warm. An oral pharyngeal breast milk, starting off as buccal colostrum, but then continuing to put drops of breast milk in the baby's mouth, may also reduce the risk of oral diversion. What other interventions might improve long-term brain outcome? Well, let's think about surgery. The trials of laparotomy versus peritoneal drainage overall suggest that if you need a laparotomy, you're probably better off getting on with that. And there is this concern that peritoneal drainage as a primary modality may increase the risk of moderate to severe cerebral palsy, but the data on this, I think, is a bit equivocal. Earlier stoma closure may improve nutrition. If the baby has very short gut, then procedures such as a STEP, serial transverse enteroplasty procedure, may improve nutrient absorption. And then there are a number of newer drugs in the market. So the glucagon-like peptide 1 and 2 agonists may increase intestinal growth and short gut. And also some emerging evidence that enteral insulin following NEC or in short gut may be potentially beneficial. What other interventions may improve long-term outcome? Let's think about nutrients. Well, every micronutrient is important for brain growth. I want to emphasize the importance of an adequate iron intake throughout infancy. Iodine, of course, critical for thyroid development, but current practices probably provide enough. Babies on prong PM may need zinc supplements. We know that breast milk from mother is beneficial. There's a little bit of data, but not following NEC, but a little bit of data that additional milk fat globule membrane may be beneficial. There's some exciting work looking at docose hexanoic acid and arachidonic acid and choline supplementation. Higher macronutrients following discharge and those with a brain injury may be beneficial. We need to avoid malnutrition, so we need to maximize breast milk. And importantly, we need to ensure that their diets meet their intake needs, especially for the key nutrients, as I say, such as zinc, iodine, and iron, but also fatty acids throughout childhood. What other outcomes may improve brain development? Kangaroo mother care results in better brain outcomes in later childhood. And this should be seen as a core component of family integrated care, thinking about noise and light exposure and the importance of sensory interventions, touch and comfort holding, all of these impact on the brain development. And then, of course, throughout infancy and early childhood, early years, educational support, occupational support, speech and physiotherapy, and thinking hard about the home and school environment. NEC is a very expensive disease. It places enormous stress on parents and families, both in the acute period and after discharge. The multiple outpatient appointments can end up dominating family life. The impacts on parents may be significant. The costs whilst they're in hospital, loss of earning potential and income, adverse impacts on their own relationships or other siblings in the family. And just again to highlight that if the babies die, parents will, of course, experience lifelong grief with a huge burden on the mother and father, potentially also the other siblings, and high rates, as we know, higher rates of post-traumatic stress disorders in parents of babies who've been very severely unwell. And sadly, also just to note that about 25% of the infants who die following NEC were actually twins or triplets from a multiple pregnancy. And this obviously has a long-term impact, that if you are the survivor and your brother or sister died alongside you on the NICU, this is likely to have a lifelong impact on your personal identity. And I pick up on many of these issues in our Butterfly project. So lots of references that I won't be giving you time to read, but if you want references, you're very welcome to contact me. So just to summarize, how do we improve outcomes following NEC? Well, we need protocols that ensure good macronutrient and micronutrient intakes. We need guidelines and practices to provide support for mother's own milk. We need to think about surgical or drug interventions that may improve intestinal growth and function. We need practices that ensure adequate iron status and thyroid function. We need interventions to support mothers to continue providing breast milk throughout the neonatal stay and after discharge. We need to think about kangaroo mother care and optimization of the sensory environment on the NICU. We need to promote practices that provide regular, fresh, non-refrigerated mother's own milk to maximize the potential of stem cells and exosomes. And we need to think more carefully about the social, psychological, family, and sibling support needs over the life course. And I'm going to stop there. And thank you very much for your attention, and apologize for not being able to take any questions at this point in time. So thank you.